for take two. Glad you did that. All right, everybody, we're going to get started with women's health and longevity. And this is going to be a really interesting conversation, not just about menopause, because as wonderful the conversation is about menopause, we don't stop there, okay? The women who are post-menopausal, we have medical issues, medical concerns, and we want to live a longer, healthier life. So, with that getting started, next to me is Dr. Doris Day. She's a board-certified dermatologist, that's right, one of the top board-certified dermatologists in New York City, and we have, I know Mindy has a bunch of questions she's excited to ask her about. And next to her is Dr. Somi Javaid. She is co-founder of HerMD. And HerMD is changing the way women's health in our demographic is being taken care of. Imagine having a 45-minute doctor's appointment as opposed to 15 minutes with your list of questions. And next to her is Dr. Hirsch, who is also changing the landscape with, and now she has a private telehealth community. You know, as we've mentioned, I have a podcast, and one of the first doctors that I talked to was Dr. Hirsch, while in her basement, because it was a pandemic, her kids were upstairs, and she had opened the first midlife and menopause clinic at Harvard's Brigham and Women's Center. I didn't know that was a thing. I was like, you can have a midlife and menopause clinic for women, so we're not sitting in a room of pregnant ladies just hoping one doesn't, go into labor. And we can actually have our appointments. So we're going to be talking about everything today. And I kind of would like to start with Dr. Hirsch. There's still so much misinformation on menopause. So for once and for all, can you explain perimenopause post for the audience?
Okay, am I on? Yes. Everyone can hear me. I'm a loud talker anyway, so I think starting with the definitions is always good, because even as I talk on social media, we throw these terms around all the time, and then it can be really confusing to really understand where you are in the transition. So it's easiest actually to start with what is menopause. And menopause is when it's been 1 year, a full 12 months, not the 8 or the 9, which always happens, without a period. And that day is menopause, and from that day on, you are always post-menopausal. So you're always post-menopausal if it's been a year of no bleeding. Now, some women don't bleed. They've had hysterectomies or contraception or an ablation, so they can't use periods, so that's a little frustrating. But then we use lab work, and so you can see a high follicle-stimulating hormone, or FSH, and a low estrogen. That's how you know it's menopause. And then perimenopause is all the time leading up to that. So that could be anywhere from 1 to 10 years. The average age of perimenopause per the CDC is 47, although I think it is much younger. We all do. Because that would mean that doctors are putting in the correct diagnosis for perimenopause. We know that they're not, because that is actually a diagnosis based clinically. So I'm the clinician, I decide based on your set of symptoms. So perimenopause, all the time leading up to menopause 1 year since you had no periods, and then you're always postmenopausal after that.
Thank you, because I think a lot of people have this idea, I'm in menopause, when menopause is actually 1 day out of your life, and then you're post. And you can't be in menopause like for 10 years, you can be perimenopause for 10 years. But I want to just speak with Dr. Javaid, because Somi, you have a really personal story about how you had started in your mom's cardiac health. Can you tell that story?
Why am I always the depressing one on the panel?
I promise we'll lead to better.
I got a call, Somi, you need to come home. My 45-year-old mother, who had been dealing with chest pain, shortness of breath, and left arm pain, was continually dismissed by her doctors. It's caffeine. It's your children. Me? I was like pre-med at Northwestern looking at the CKG, going, this is angina. And so I made a vow to her. She survived. She had emergent quadruple bypass surgery. We were insured. We lived in Cleveland, the Mecca of cardiovascular care. Her problem was that she was a minority woman, There was no data. She was thin, non-smoker, but got dismissed because our healthcare system is so broken. So broken. So I made a vow to her, to myself, and to all of you that I was going to change healthcare. Lo and behold, I was in for a little ride, and lesson, and humility, and humble pie. After seeing 50 patients a day, not being able to eat or go to the bathroom, I was like, I have an idea. My husband says those are the most dangerous words that ever come out of my mouth. I'm going to start my own practice where I educate, advocate, and empower. See patients for an hour in an insurance-based system. So I opened a small center in Cincinnati, Ohio for menopause, sexual health care, and gynecology, and witnessed women from 35 states and 3 countries coming to Cincinnati, Ohio. I mean, we're cool, but we're not New York. We're not known for medical tourism. And then my co-founder, sister, was like, we need to scale this. Well, 2 brown women, we talked about investors, 2 brown women from the Midwest, we were told less than a 0.5% chance. $30 million later, we have opened 4 centers and we're continuing to grow across the country.
And also, you know, I think something that happens to a lot of us and we don't know what to do about it is menopause, post-menopause, our skin is changing. And some of us think we're going back to puberty in high school with acne, that where did that come from? And some of us just have a dryness on our face and other areas. We'll get into those after. But what is happening to our skin?
Well, with estrogen depletion, your skin collagen starts to break down. We don't make new collagen. So the idea is that we really need to protect the collagen we have. And so a lot of the things you did when you were younger, you're going to continue to do as you hit peri and post-menopause. But it's also about the holistic approach. It's what all of us do. I refer so many women out for hormone replacement therapy. And a lot of my conversations are around things I don't do. I help them understand how important hormone replacement is and go through the data and why they were so misinformed on what the safety is around hormone replacement. And I tell them, look, I care about your skin. I don't want your collagen to break down, but it's also affecting your brain, your heart, your bones, all your other organs. So the bonus is your skin's gonna look beautiful and all your other organs are gonna be better as well. And I say selfishly, I want what I do to look better, last longer. And hormone replacement's a big part of that. And what women don't realize is how young they may be when they start to enter that perimenopausal phase, and they think that they have to wait till they are post-menopause to start the replacement, when in reality, it's really in perimenopause that if we start to replace early and combine that with great skincare, weightlifting, other exercise, watching our diet, managing our sleep and our stressors, all of that together shows so beautifully in their skin. So your skin isn't just a reflection of your health and well-being, it actually affects your health and well-being. So when I do things, whether it's laser or fillers or whatever else I do to help them look better, it affects every other part of their life. And it's so beautiful to see women come in, posture better, chin up, eyes more open, just looking at women who end up getting divorced, not getting divorced, having different relationships with their family because of their self-confidence. And helping them navigate their aging process really well. And my focus is really longevity beauty. So it's really about anti-aging in a way, but helping skin age younger as we go through time. And it's possible. So I just helped co-found a new company, and we're working on a novel molecule which should be out in about 1.5 years. And this is hopefully going to really change what we do topically for our skin and our hair, because hair is a big component of this as well. And women start noticing hair loss, a lot of that needs hormone replacement as well. But there's so much on the horizon for women, so this is a great time to be getting older because we're not going to look it.
Is there a sign-up sheet to testers?
Yeah.
You know, we talk about women's health on this panel, and I think it's really important for women to understand cognitive health, cardiovascular health, your osteoporosis. And I'm noticing in the research, and I'm just a novice at this, but I'm noticing in the research that HRTs are becoming preventative, almost like take them proactively. So, Dr. Heather, what are you seeing from your patients as far as when to take HRTs? Are they, if they choose to? Again, this is your personal choice. Is it helping? Timing is everything, I guess is my question.
This is such a great question, and since I've been doing menopause for the last 10 years, also in Cleveland, which we call the mistake on the lake, so nobody wants
Hey now, let's not pick on the Ohio girl, please.
You know, so during my training, when I was learning from my mentor, Dr. Thacker, during my fellowship training, you know, if I go back and transport myself to 2016, even when I was a very small little baby doctor, women would come to me and, you know, I would say, what do you think would help you? Or do you have an idea what this is? I mean, I would never hear like I do now, well, I need progesterone and the patch and dab of testosterone and some vaginal estrogen cream. Okay, your visit's gonna be very easy. But, you know, many years ago, we weren't there. And now, women are coming to me saying, I hear that this is preventative for me. This is light years ahead of where we were or where I was even 5-6 years ago when women really didn't know. Now, I'm not saying that it's a million times better, but it is so much better. And so they're saying, I'm hearing that I want to discuss hormone therapy, not just for my hot flashes, which suck, but I can handle that, or my brain fog, which is actually really bad and I can't work at my job, but because I want to live a long, beautiful life for my kids, for my family, and for myself. So where does this come from? So the biggest study that we all have heard of is the Women's Health Initiative. And we always say this bad study was debunked. This was actually a really good study. What this study showed, because it's the largest study that we have on hormone therapy, and actually one of the largest randomized controlled trials ever done, which means hundreds of thousands of women went before us to line up and do the Women's Health Initiative, not knowing, you know, the outcome or what it was going to do. They were trying to do their best to give us information. What they found in that study was if you started hormone therapy, which is an estrogen, plus a progesterone if you have your uterus, within 10 years from your last period, so now we know menopause is that birthday, then actually women lived longer, on average 3.2 years later, who's counting, had less cardiovascular disease and less heart attacks. Yep, heart disease being the leading cause of death in women. Less diabetes, which is wild. I tell this to my endocrinologist and they're like, no! Yes, less diabetes, which is one of the most impactful chronic conditions that we have. Better bone health. 1 in 2 women will suffer from an osteoporotic fracture. Less urinary tract infections, of course, better quality of life, better sex life, no hot flashes, better sleep, all of those things. And this shit is hidden in plain sight. This is not opinion, this is fact. Now, every year, the U.S. Preventative Task Force Services, I know, every year, the U.S. Preventative Task Force Services, which is made up of, I don't know, a couple of clinicians, decide grades, literally like a school grade, A, B, C, D, and E, and F, and like probably G, for the use of a certain medication for primary prevention. Primary prevention is taking something to prevent something from ever occurring. Versus secondary prevention, so your mom, she had a heart condition, now she takes a medication to prevent that secondarily from happening again. Every single year, when the USPSTF comes out with their recommendations for hormone therapy for primary prevention, I get a slew of text messages saying, Heather, can you believe this? And I'm like, of course I believe this. It gets a grade F every single year. Every single year. Even though there is stone cold, hard data that estrogen improves women's longevity. So brain health, which we're doing a lot of studies on now, cognitive function, working longer, living longer, having less heart disease. This should really, really piss you off.
Decreased risk of mortality and cardiovascular disease, particularly when you start that hormone within the first 10 years of going into menopause, but no one called a damn press conference for all this positive data. You guys just all heard the negative data, and that's why prescribers stopped learning and women stopped taking.
But I find the biggest obstacles are other physicians. When I talk to my physician colleagues, they're the ones who say, I would never do that and I would never prescribe it. So for me, as a dermatologist, I talk about this with my patients and I tell them all the time, I don't prescribe this, but I'm spending all this time helping you understand it and then referring you to somebody else who's going to prescribe it because it's that important. But finding a physician who understands it, knows how to measure. I was just speaking with someone today and she went to a nurse practitioner who's giving her estrogen by mouth instead of giving it to her as a patch or a cream. And I think even that, some doctors are saying, well, just take this for a while, just go on Prempro or take a pill and go on the pill for a little bit longer, but that's not hormone replacement. And most women don't realize that the hormonal contraceptive that women are on for 20, 30 years are higher concentration estrogen most of the time than in hormone replacement therapy. So women will do hormone contraceptives for decades, and then when they get to perimenopause, they're like, oh, I can't do that, breast cancer. And meanwhile, talk about the breast cancer, like what is the real data on that? And I think women will be shocked at how little they have to worry about it.
Well, the estrogen-only arm actually showed a decreased risk of breast cancer and a decreased risk of dying from that breast cancer. And we're graduating 93% of our medical residents with zero knowledge of menopause.
Yep, my daughter just graduated med school and I can tell you, zero education on menopause. I had to educate her.
And we're going to spend 40% of our lives in menopause. Who are we going to go see? Hello, there's only one of you.
Well, I also, just obviously learning about all this, going through it. I came into the party going, estrogen, my vagina, my uterus. I know what's going on down there, but there are estrogen receptors in every part of my body.
Especially the skin of your face. And the way that I know women are in perimenopause, they all come in and they say the same thing. One day my face just fell apart. That's how I know that they're in perimenopause. And that's when I know to refer them out.
That's so interesting. I think they were saying that with cognitive health, Alzheimer's, it's like 2/3 are women that get Alzheimer's. Can one of you discuss why is that? Is that the estrogen loss?
Yes.
I know, but I want them to.
Yeah.
Thank you. Dr. Mindy's going to take it.
No, it just was leading to my question that there are estrogen receptors, which is something I didn't know, in every major part of your body. And so it's obviously affects, we kind of turn into men, literally, when we lose our estrogen, right? And I learned last night about that our guts actually change and take on like a man's gut.
So changes in the brain are due to lower estrogen levels are independent of aging. So you are absolutely correct. So we are at an increased risk for developing Alzheimer's with decreasing estrogen levels.
So I talk to my patients about this all the time. And in fact, a patient came to see me yesterday and said, I've never felt suicidal in my entire life. Never. I'm the happiest woman. I love finance and I love real estate and I lay up all night now because I can't sleep selling my stocks. And when I turned 51 and my period stopped, I just wanted to walk middle of the street for no reason. And I said that the place where we have the most concentration of estrogen receptors is in our brains. So our prefrontal cortex, which is like the decision making, that's why through the perimenopause to menopause transition, women have what they call brain fog, trouble with memory, concentration, processing speed. In the middle of our brain is where like the hippocampus is and where we have memory and mood. And the back of the brain, the hypothalamus, is our core body temperature thermostat. So all those hot flashes, all those vasomotor symptoms that we talk about is all brain and CNS or central nervous system related. So in the hypothalamus is where we're controlling our core body temperature. And treating women for 10 years and treating thousands of women, the impacts that estrogen has on mental health are so immense that of course, this all has to do with the blood flow and the estrogen receptors as we age and how our brains function. Because Alzheimer's is 4:1, women to men.
I do also want to, the vasomotor symptoms, when people say, oh, it's just a hot flash, the severity can be an underlying clue that there may be cardiovascular disease going on, and you know that's near and dear literally to my heart because of my mother. So it's more than just a hot flash.
And it can also affect your joints. When you get up in the morning, you feel a bit more creaky. And that means you may need to adjust your estrogen level. And unfortunately, so much of what we put towards menopause and perimenopause is just hot flashes. And I have so many women who come in and say, well, I'm doing just fine. I don't have any hot flashes, as if that's the only symptom. But in reality, there's so many other more subtle symptoms. And I would love to hear from you about women who really seem to not have symptoms. They don't have the brain fog or the hot flashes or the joint aches or the anything. Does every woman benefit from hormone replacement? And then the other thing that women ask me all the time, since I'm taking over the moderator here.
We're just, Mindy and I are just here for the ride.
Is women who say, well, my doctor said I can never go on it because I have a family history. They don't have BRCA, but the breast cancer risk is so high in women's minds that they're almost willing to tolerate all those other horrible things, early dementia, osteoporosis, fractures, joint aches, everything else that goes with it, because breast cancer is what is mostly on their minds. So how do you address that?
I mean, it's a curated individual approach, but I offer women therapeutic testing, gallery testing, and MyRisk testing, so they can make an informed decision, not just, oh, well, it happens somewhere in your family, so it's a no. Can you imagine if we did this to men? Walk around demented with a dry penis and hot flashing.
No, I think it's actually malpractice to not inform women.
I'm serious! But we have like 26 medications for erections. But women, we don't treat and haven't treated for 2 decades. It's crazy. No one would let men walk around like this.
But even if we talk about just the pure numbers, from my understanding of the data, your risk as general population of breast cancer is 4 out of 1,000, and on hormone replacement it goes to 5 out of 1,000. Now, the problem with the way the data is presented and the breast cancer worry came from looking at risk in 2 different ways. So if I said you can win the lottery, you have a 1 in a billion chance, are you going to win the lottery? No, right? 1 in a billion, chances are nothing essentially. If I double it, if I go 100% more, if I double your chances and go to 2 in a billion, are you going to win? No. So your absolute chance or risk is still essentially nothing, but your relative risk just doubled. So with breast cancer, the way that it was presented wasn't the absolute risk of going from 4 out of 1,000 to 5 out of 1,000, which is basically 1%. They talked about the relative risk, which is 4 to 5, which is a 20-something% increased risk. So the sensationalism of the data, I was a journalist before I was a doctor, I was a medical reporter, and everything is about getting the headlines and the scoop. So the scoop was, risk of cancer goes up 20%, but they didn't say it's the relative risk, which is the difference from one to the other, not your absolute risk. And that's what got women scared, and the only thing that stuck is 20% higher risk of breast cancer, or 27% higher risk.
And that was only in the E plus P arm.
Right.
And that new study
Estrogen
just came
plus
out.
progesterone.
Yes, over 65, and estrogen alone, once again, decreases our risk of breast, lung, colorectal cancers, Alzheimer's.
Yeah.
When we talk about the preventative benefits, even in the WHI, all cancer mortality was lower in both of those estrogen and progesterone arms. And what we see is that that data, which is so good because it's not that scary, was on the oral Prem-Pro.
Of course you're an estrogen, not the bioidentical that we use today.
And now when we look at studies of women who are using estradiol and prometria or micronized natural progesterone, we actually see no increased risk of breast cancer above baseline, which means we all have a baseline in this room. And if you avoid HRT, you stay the same. If you take HRT, you stay the same. But there is this sort of interesting idea that if you don't take it, that will lower your risk. In fact, since the WHI came out and the use of hormone therapy dropped precipitously from upwards of 57% to about 2%, breast cancer diagnosis has gone up. So we have better screening. And what this really means is that it's really fascinating how forces greater than us have told us what is important for our health. And the thing is that when you think holistically about your body, about your quality of life, about your longevity, about your heart, it really is so impactful knowing all of this information and then making an informed decision.
And I can tell you as a dermatologist, I can tell which of my patients have been using or taking hormone replacement. The skin quality is so much better. What happens through perimenopause and post-menopause is that your skin gets thinner. That's why we get vaginal dryness and your mucosa gets thinner. So we try all these things. You can use retinol, you could do lasers, you could do fillers, you could do all this stuff, have a facelift. But if your skin quality isn't good, you end up looking filled out or pulled, but not more youthful, not even younger, just basically done. It's not a good look on anybody. So as we get older, there's a certain amount of acceptance because your skeleton is changing. Even with hormone replacement, I learned like, oh wait, no, you still do get older. It doesn't turn it off. It just slows it down a lot and makes, so that's where longevity beauty comes into play. And I think that there are really great things like rapamycin, metformin, other things that are going to really change the aging process. And that's a lot of what I do. But even if you just look at doing hormone replacement plus these treatments and accepting that your skeleton is changing, all the layers of your skin are changing, and your bones, your ligaments, your muscle, the fat, the layers of the skin age at different rates. There's no way at 50 you're going to look 20. And I actually think 50 is the worst decade because 50 is when you start actually feeling like you look older. And I asked plastic surgeons, like, what is the best age to have a facelift? And they said, when you think you look like you're 53. But what's great about 60 is that at 60, you realize you are aging and there's a certain amount of acceptance that comes with it. And then you start to see your beauty. Then you start to look in the mirror and go, oh wait, I have these great features. I can look balanced. And you stop trying to think of yourself as beauty in terms of fertility. Because so much of what we think about beauty is about the idea that you're fertile. And that's hardwired into our DNA. And the other thing that's hardwired into our DNA is looking for problems. How many times do you go look in the mirror and you go, ugh, right? We all do that. We all look in the mirror, all we see is our flaws. The first thing I do when I have someone look in the mirror is I go, oh, look at your beautiful eyes. Look at how your face frames, your hair frames your face. Look at that beautiful bone structure of your cheek. So if you start trying to look in the mirror at 60 or when you start hitting your 50s and start looking for what you love about how you're aging, you'll change the whole trajectory without even having a treatment or doing anything. And it has such a powerful impact.
I wanted to clarify something, real quickly about transdermal. So we talked about oral versus transdermal. So we know, and the studies show, that, and by transdermal we mean on the skin. Patch, spray, gel, I mean, your choice. I don't care. It's just a different delivery method, and it's covered differently by a lot of insurances. But we know that's safer, less risk than oral estrogen. Just wanted to make that.
That's what I wanted to ask you. That's because somebody else had just said about taking it by mouth, and I said that is not as safe. Why is it not as safe?
Well, we know that. Well, there are new bioidentical formulations of oral estrogens, but the old ones were, like you said, conjugated and had multiple different molecules of estrogen in them that are not identical to what our body makes. That being said, please don't pay thousands of dollars for someone who is trying to sell you a bioidentical. There are FDA-approved, insurance-covered formulations.
When you talk bioidentical, Dr. Hirsch, could you make it very clear what bioidentical really is?
You know, I remember, when I was in fellowship, no one wants to hear my whole story, but I actually wanted to be a I did a year of OBGYN, and then I thought I was going to be a breast oncologist. Then I ended up doing a fellowship and prescribing hormone therapy. And I remember walking into my fellowship, and I had no idea what bioidentical meant. I mean, I was so embarrassed. But again, how would I know? No one was going to teach me that in my seemingly fantastic OBGYN year or internal medicine residency at Case Western. So bioidentical, I always say, is a marketing term, and it is the best marketing term because it sounds so lovely. It's bio, and it's identical to me. It has like a very feminine feeling, right? And natural. It pulls to everything that we would just naturally gravitate to. I tell my patients, anytime you hear the word bioidentical, just swap that word out for estradiol. And for the progesterone, swap that out for prometrium. That means that the estradiol is plant-based. Now, we can't go out to the street and like get enough plants and eat enough yams. That's not going to do it. But it really just means estradiol. So of estradiol, you can either have compounded, which is unregulated. And the problem is that we don't have the same data for those preventative studies and all the things we've been talking about, as well as the safety. And then there's bioidentical that is FDA approved, that you can go to CVS or Walgreens or Rite Aid and you can get for very inexpensively. And you might want that if you're taking HRT for a long time, of which there's no time limit. We can talk about that later. So that's the difference between bioidentical. Anytime you hear that word, just swap it out for estradiol and prometrium.
Mindy, you were going to ask me a question.
Well, I was listening to Dr. A talk about her skin, and I just wanted to talk about my new favorite skin, which is my vagina. Because I have had a real just life lesson about my estrogen cream up my hoo-ha. And it's been really, I just had no knowledge about it. Now, I am very lucky. I have an OBGYN who keeps herself not only informed, but really has all the answers and the suggestions. And I am one who does not want to take hormones. Having said that, I am 58 and still never been married, technically, so I would like to have a husband. And my doctor said, you know, would you like to have sex with this husband of yours? So my libido is like a 13-year-old bat mitzvah boy. But she apparently said my vagina is not matching that libido. We started on this cream, and I just feel this. I want to hold up a banner that every single woman on this planet should be taking this cream. Yeah, if nothing else, and I'm one of those nothing else's.
But Mindy, after our conversation, are you more inclined to consider?
No, and it's not based on anything you have said or I have said. A lot of it for me has been hereditary. I am one of those women who did not suffer, and I'm not suffering, and I'm doing a deep dive into aging. My song is Let It Go. Let it go every time I want to tip, tuck, nip, suck. I think about my career, and I sing Let It Go. And we're all just going to let it go in age. I'm looking forward to it, actually. I mean, it is. Having said that, quality of life as a woman, and knowing what I know now, and I knew that I was seeing you, and I wanted to talk to you about this cream has legitimately changed my life. And I do think literally every single woman, if she does everything and nothing, needs to get on this cream.
Yeah, so what Mindy, if you guys are confused, you're like, wait, she's saying no hormone, and then you're putting estrogen in your vagina. What's going on? So, there's a multitude. There's so many different options. Yes. And it's not just a cream, there's suppositories too. And there's also devices. I mean, there's lots of things that can change the collagen, elastin, and blood flow. I like the way they all want to go see you afterwards, and I'm like, okay, I take insurance, Mindy doesn't. Just for the record. I know she thinks that way with Kristen Wiig and Ricky Martin.
And it's why I specifically wanted to talk to you, though, because we had talked about it in Nashville.
Well, the reason I'm so passionate about it is whether you're sexually active or not, we have to take care of our skin, right? And women see you for all the other skin. But as we age and we lose estrogen and testosterone and progesterone, our vulvar and vagina change. We get something called genitourinary syndrome of menopause. Vaginal dryness, sexual pain, frequent urinary tract infections, vaginal infections, and so,
Potential to have them.
yes,
Talk about preventative. This cream is like
huge, life-changing. We spend millions of dollars on UTIs in this country.
Is there
right
a
now.
systemic absorption of that? Is she getting systemic estrogen from this?
Very, very little,
correct.
not measurable.
correct.
So that is considered localized treatment.
It
So even
doesn't go
women with
anywhere
breast
else
cancer
in the
could use
body.
it oftentimes as
Stays there.
C-string.
So I say yes, ASCO says yes, my husband who's a medical oncologist says yes, but you will still find oncologists that say no. Absolutely
See,
not.
this is the problem I have with hormone replacement is that no doctor will ever be faulted for not prescribing it and saying, do you suffer with that vaginal dryness, those UTIs, all the other symptoms? But nobody's gonna fault them for not prescribing it, but God forbid you use it and something happens, you get unrelated breast cancer or something else, they feel medically liable. So a
Also-
doctor's more likely to
But
say no
also
than
with,
yes
with
to cover
older women
themselves.
and sepsis, and 20% of women who enter hospitals in their older age with sepsis, this is all preventable.
I
You
don't
can
disagree.
die from
I don't
you can die from menopause.
Yeah.
You can die from GSM. You can lose a relationship. A lot of women when they stop having sex, they like lose their confidence. They lose a part of themselves, and so it's very, very distressing.
It goes to the system is broken.
But very, very little is absorbed, and the majority of the oncologists are okay with it. But you will still find oncologists that tell their patients, absolutely not, in zero.
And I am a cancer survivor, so I'm on it.
Heather, myself, Rachel Rubin, most of us who are leading the charge,
Yes.
we want it in the water.
We want it like a CVS. We want it at CVS. So, the oncologist or the neurologist or whomever is not the boss. You get to decide, and there's so much safety data. But you all reminded me of a really important statistic is that there are 3 things that will land a healthy woman in a nursing home. A fracture that could be prevented by hormone therapy, urinary tract infections causing urosepsis, of which I have seen women die from, and Alzheimer's, and we touched on all of those. And so important what Mindy is saying is that there is no one size all, and so not everyone needs, or there's no one right answer. I say that every single day. I love talking about hormone replacement therapy, and we all do, because we all have to work together to uncover all these myths and misconceptions and then make the decision that feels best for you. But truthfully, everyone should have vaginal estrogen. It comes in a cream, it comes in a suppository, it comes in a ring, and it should be at CVS.
Well, and I gave a keynote lecture, and I had a gentleman come up to me. I know we were kind of like talking about investors, and I have my own stories. And he was like, "My God, Dr. Javaid, my marriage ended because of GSM, and I had no idea until you gave this lecture because my wife was having sexual pain. I took it as rejection because obviously her libido or her desire went way down." Because who wants to do something that hurts? Most of us don't. So it's very natural as we experience pain that we're going to avoid that activity. And so it just snowballed into no one wanted to talk about it. They were avoiding each other. They stopped having sex, and the marriage ended. And so that was a huge event for both of them, and so preventable. And so that's why when people say menopause doesn't need to be treated, it's just a lifestyle thing. No, people can die, they lose their relationships. Women lost $1.8 billion last year in the United States and lost workforce-related issues because they have GSM and they're worried about not being able to go to the bathroom. There's no cooling rooms. And so we are losing a lot in the prime of our lives by not treating menopause.
So there's this whole other market that's building around treating the symptoms of menopause without treating menopause. I think there's a new drug for the hot flashes. I'd love to get your take on what you think of those, and that's from both of you.
Yes, so this new drug's called Veoza or Fezolineant, and I was talking about those receptors in the back of your brain that cause hot flashes, so it binds to those receptors. I don't think it's bad or good. I think that all tools in the toolbox are so important. I too had many breast cancer survivors come to see me, and for many reasons, there's many different personal opinions on how you're going to treat that. I just had a patient do so well on this medication. She's so excited. Of course, it's $500. And so the more tools in the toolbox we have, this does mean certain things. It means that pharmacy is listening. It means that investors are listening. It means that, I mean, they had a commercial of the Super Bowl. Was it a waste of money? I don't know. But it means that the tide is turning. So I think that every step we make along the way is great. You know, a lot of people were saying, oh, with this medication now doctors are definitely going to stop prescribing HRT. That didn't happen. And so I think that what we're seeing is a shift in how women's health is, you know, to be managed and to be treated. While it's very, very slow, it's still a really good sign. So, you know, I still think hormone therapy should be counseled to women as the most effective and the first line treatment. But the more tools we have in the toolbox, the better.
Same thing, curated approach, depending on symptoms, depending on whether or not the patient wants hormones or not, or if they're a candidate. And then it's really nice to have 2 FDA-approved medications for low libido or HSDD. We have Addyi and Vyleesi. To have 2 FDA-approved medications for hot flashes, Veoza and Brisdel, that are non-hormonal. I mean, that way I can really talk to my patient about a curated approach, and it's like Heather alluded to, it's her choice. She's a partner in her healthcare, and we decide together based on everything else that's going on with her health history, medications, and bottom line, her choice. But if you don't know about the medication, then you can't opt for it, right? It's like going to a restaurant and not being offered a menu, and I think that's the problem in this country. When we're not educating our providers, how are they going to even opt to give you guys those options? How many of you guys know that there are 2 FDA-approved medications for women's sexuality? Who knows what Viagra is? Right? Once again, right? So it's, we really, really have to change education in this country.
And I think this has really showcased that there are educated women doctors and male doctors that know this stuff. But if your doctor does not, it's okay to break up with them. You don't have to be in a long-term relationship with your doctor if you're not getting proper care. Come on, how many women will go, oh, I've been with this doctor 20 years, I can't find you. They'll get over it. They don't mind.
I have to tell you this story. I saw a patient yesterday who flew to see me from a southern state, and I don't want to, you know, and she had to have a hysterectomy in her 30s, and she had something called vaginal dehiscence 6 times. She was never given vaginal estrogen after her surgery, and she was in premature early menopause. Then the doctor gave her pellets of hormone therapy, and she came to me, I am not even making this up, with new onset of kidney disease, diabetes, and lipid panel dysfunction. Her testosterone was really high. That's not the point of the story. The point of the story is I said, I think you need to sue your doctor. And she said, but I can't. She's trying her best.
Right, exactly. Like, you deserve the best medical care out there. Just like men are quick to just go here, and it's okay for you to say, you know what, if you're telling me this is just menopause, maybe you don't know enough about menopause, and I deserve to know more. That's something that you deserve. And it's okay to say, here's an article that I read, or I went to this event and I learned. This will be videoed because I know you're not going to remember everything the doctor said. But, you know, I learned about Veoza, which is a new FDA-approved non-hormonal treatment. Can you find out about it if you don't already know about it? And it's okay to don't be afraid to know more than the doctor. It's okay. I wanted to get, I know we're short on time, but I wanted to get another thing that we hear a lot on the podcast is as women get older, their hair loss. You start losing hair. What's happening and what can we do about it?
Well, your hair does naturally age, so over time you have less density of hair and each strand becomes finer. So female pattern hair loss is as common. 50% of women by age 50 are noticing hair thinning and hair loss, and it bothers us. And again, going back to our DNA, we're hardwired to care about hair because let's say you see an animal that has a beautiful thick coat of hair, you think, well, that's a healthy young animal, right? So with us, it's the same. You see somebody with a thick head of hair, we're thinking fertility. So as our hair thins, it affects our self-confidence, it affects our self-esteem, and hair thinning and hair loss female pattern can start as young as in your teens or 20s. In women, I see it all the time. It's about 30% of my practice is treating hair issues. And as we age, it gets more and more. So the only product that's FDA approved for women is minoxidil topically, which is FDA approved, but it's considered so safe by the FDA, you can sell it over the counter without a prescription. We have a lot of other things we can do for hair. There are supplements that help. There's other drops. There's topical exosomes. There's lasers. Some women do take finasteride or dutasteride. A lot of doctors give that out like it's water, even oral minoxidil, but all of those can affect your libido. They can affect your liver, and the data in women is not that strong. There's a reason that finasteride didn't get FDA approved for women. It's because it didn't work for most women. So what they do is they just give it at a higher dose, but that also has side effects. So there's issues around it. But there is a lot you can do for hair, for women to help regrow hair and maintain it. Even just shampoos and thickeners and powders and topical things to get you from one shampoo to the next. But it's very common. And then you can have play hair. There's like clip-ins and wigs and different things you can do to have fun. And I would love to see what I call play hair or travel hair. Just think, when you have play hair, when you want to get your hair done, just send your hair out. It's like, it's so nice you actually have to go in and have your hair done for 2 hours. So we just need to normalize these things, not be self-conscious or think that it's, we wear glasses and jewelry and change our outfits. I mean, we could not make it such a stigma around thinking about chemotherapy and cancer when we think about wigs and play hair. But hair loss is a problem. Hormone replacement absolutely helps with that. The sooner you do it, the better your hair is going to be as you age.
Can we join me in thanking our doctors? Thank you to Mary Giuliani and her amazing company. We have some food, so help yourself.
And guys, just remember, all the doctors' links and information are on the back. If you want to learn more, follow them on social media. Dr. Hirsch is constantly saying, I just saw a patient that da-da-da-da-da. Here's what I told her. Dr. Day, she will say, do you want to use retinol on your whole body or not just your... They answer your questions, so it's worth a tag, social media. I have it all in the back of the program, and just follow them. You'll learn a lot more than